And now, next we move on to our chief talk of today. That is by Dr. Sandra Ganesh. She doesn't require any introduction. She is a well-known pediatric ophthalmologist and she is doing so many works in CVI. Over to you, ma'am.
Thank you so much to Dr. Geeta and the organizers for giving me this opportunity. And we have been listening to very good and fantastic talks on CVI, both evaluations and interventions. So, as you know, I think CVI is emerging as a leading cause of visual disability, much more than even retinopathy of prematurity. I think it's around 30% now of all visual impairment in the 0 to 1 year age group. So I think you have got a general idea about the interventions by the previous speakers. So the general principles of intervention will be first, in an older child, you prepare the child. Like for example, try to follow a routine. Like this is true of any visual impairment because the child may be able to anticipate what activity you are going to do next. So if the daily activities has a certain routine, then the therapy is much better. Posture, like for children with cerebral palsy, most often like cerebral palsy associated with CVI, so we need to give a adequate posture support. For example, if the child is severely hypotonic and you are forcing the child to sit, then all the energy goes in trying to sit. So the child will not be able to keep the head up and then the child will not concentrate on the therapy session. So you will have to give a proper posture as a chair where you can give a support and also give a neck support if needed, and then you start the therapy for the vision. So then descriptive language, like when you are trying to talk to an older child, like use a descriptive language like the radio language they will say. Like you try to describe the scene because the child may not be able to take in the message from the environment as how you are seeing. So you have to use a little more description to what a normally sighted child would need. Enhance the facial contrast. So we saw how the testing should be, at what distance the mom should keep the child in front. But you also have to increase the contrast of the mother because otherwise the mother's face appears as a big blur. So you try to enhance the contrast. Like for example, you can use a shawl or you wear bright colored clothing, or even you can use some like makeup and all, like that's what they suggest. Toys that match the threshold of vision. So you don't use very tiny objects to do the therapy. You have to match the threshold of vision as how you are testing with the Lia paddles or the preferential acuity, so that size of all the material should be matching that. Otherwise the child is going to lose interest. Use simple background as far as possible. And when the child's vision is poor but the child is good in hearing or touch and other things, so you have to rope in the other senses. Try to do a multisensory stimulation. But sometimes that can not be, like sometimes a child can get averse to hearing loud sounds also. So you need to do that on a case-to-case basis. So plain background, and another thing is the refraction. So the refraction is very important. Give the correct refraction. A small degree of myopia may not be actually needed to correct. A small astigmatism may not need to correct because the child finds very difficult to wear the glasses. But significant refractive error you need to correct. And always try to give a magnification because many of these children have accommodation issues. So you test accommodation with a monocular estimation method, and if you are finding an accommodative response, then this may not be necessary. But if there is a lag of accommodation, then definitely you need to test. And as the previous speakers have said, you can use the plus classes, +1, +2 or +3, kept handy in the clinic and then you try to test the performance of the child. So sometimes in severe accommodation issue, it will have a magical response when you put a +3 glass. The room lighting is very important because some kids do well in brighter light, some kids do well in dim light. So by the performance of the child, the room lighting needs to be adjusted. Functional vision assessment and all is mandatory. And don't be very enthusiastic. Like the child would have booked for a 1 or 1.5 hour therapy session, but the child may not be in the mood. like the child will be crying or the child will not be receptive at all, try to include some break time in between the therapy session. It is very exhausting for both the therapist and the child. So just build in some play break or some rest break in between 5 or 10 minutes to again get the attention. And it's always a team approach. So try the glasses first, I already said, but also the glass, if it is a high plus frame and all, so it also acts as a peripheral blinder, like the child is not able to see beyond the glass. So that may itself help in giving a focus. And because sometimes the features of CVI also mimic an ADHD. Many times we may feel like that, but this may actually be helpful to prevent that tendency of the child to not concentrate. Accommodation, I said. And simple background ambient lighting, you always use one at a time. Like, don't keep the room like this. Like, you should avoid the clutter. Use simple, even in the bed sheet, you instruct the parent that it should be a simple bed sheet, not a patterned one. And way the child's toys are arranged, clothes are arranged, everything, it is important. That is why you can organize some Zoom session or something. You can even connect the parent with the home. Try to see what the home looks like, because the therapy is not only with you, also you need to see what the house and what materials they have in the house and guide them accordingly. So for example, this is a 7-year-old boy born of a full-term normal delivery and with a normal birth weight, and he had a strabismus from age of 1.5, but delay in milestones. And so the MRI has periventricular leukomalacia finding, but the visual acuity is completely normal. When you test the vision, they're completely normal, but the parents are having a list of complaints, like unable to write in a 4-line notebook. So sometimes it is very difficult because the lines are also of very less contrast. Then problem in mobility. The child is bumping into others. Child has difficulty in climbing downstairs. They are not able to identify dropped objects. Difficulty in unfamiliar places. Difficulty in identifying parents. So what are all the problems? Like, why, in spite of having a 6/6 and 6 vision, why is the child facing so many issues in the school? So this problem may happen in many preterms where we are not testing for the higher visual functions and also many of the features of CVI. So the inability to write in the 4-line notebook may have many issues, like they may be having a contrast issue. They may be having the visually guided motor aspects may be not up to the mark. And they are bumping into objects or climbing downstairs because the lower field defect. So the fields has not been assessed, only the visual acuity has been assessed. Then similarly, same reason for not finding the dropped objects. Difficulty in unfamiliar places because you have the wear pathway. You know, like the wear pathway is very important. Both, you know that CVA causes dorsal stream and ventral stream abnormalities, and any of those issues can have the difficulty in finding the route and also finding the classroom. And the inability to identify the parents in a crowd may be because of crowding and simultagnosia and other features. So there are so many problems which are possible even in a child with a good visual acuity. So the thing is, you have to be very open-minded in the, so an ophthalmologist or somebody who does not have the training for CVI may miss all of these findings. So it is very important for us to spread the knowledge among our own peers and our juniors and everyone, talk more about CVI so that they can pick up these abnormalities and guide accordingly. Similarly, for lower visual field defects, simple interventions may work. One is you can use the yoke prisms, like 4 prism base down. If you give, it can bring the lower field up to certain extent. And you have a trial of, like, you have the trial of +1, +2, +3. You can also have a trial yoke prism where the make the child wear it, and then you can ask them to climb the downstairs or pick up or have some objects on the floor and ask them to navigate it in your clinic. So you can try those. And these type of shoes which have the illumination or sound guided, can use that. And for the notebooks, you can have like reading guide so that the child blocks out the other areas. And also you need to tell you have to give an intimation to the school that they may not be able to write in the classical 4-line notebook. Either you have to darken all the notebook or you have to make special notebooks for the child. So the teacher has to understand these aspects also. The classroom seating may also be very important, and more time may be needed. So the visual array has to be simplified. The child may need to move closer to the background, not only because they are not able to see, but it also helps in gaining the attention. They can block out the other aspects of the classroom which are visually distracting. So as close to the blackboard is ideal. So coming to another example, a 11-year-old girl with poor eye contact, repetitive behavior, poor academic performance, poor attention, uncomfortable around moving stimuli in class. So it can be totally, CVI can be totally missed with this. It can be towards autism or towards learning disability or something like that. So sometimes the demarcation is not very clear. All the examples of the low functioning CVI that we saw coming in with the classical history may be recognized, but higher function deficits, we are just at the tip of the iceberg. Many of them may be actually sitting in the pediatrician or developmental pediatrician's area, where their diagnosis of CVI may be totally missed. So the diagnosis actually was autism spectrum, but when they came, you actually see that the child had some perinatal problem also, and so autism sometimes we just diagnose by offhand. They need to have the specific evaluation done by somebody eligible for that, and then they have to come to the diagnosis of autism spectrum. Both may even coexist also. So uncomfortable around traffic, fast moving animals, this all happens even CVI, because again the simultagnosia, the child may be seeing moving objects better or they may be seeing non-moving objects better, and everything comes together, again it is difficult. Fast moving small animals in playground, like in a playground area of the school, so many children are together. So there again the child may find a lot of difficulties. So motion perception, they have impaired saccades and pursuits. So that may have contribute to all these difficulties. So around running children in crowded area, which is classically a school environment, they may be totally uncomfortable. Moving balls, so they prefer slower. So if you look at the normal cartoon, even what is being played, it is very sometimes fast. Whatever the cartoons the children are seeing now, if something is slow, they are not interested in it anymore. But these children will not like that at all. So because they cannot understand it. And trouble with facial expressions, already we said. So that is why I said we have to go for more of a descriptive language. Most of the human communication is non-verbal. We try to judge the other person's face, body language, and then we see what we need to talk, or sometimes many of the perceptions are non-visual. But when the child has CVI or some visual disability, then this whole thing is not there. So how we have to talk to such an individual is, if they are having difficulty with it, one thing is with good visual acuity, they may be again unable to recognize the emotion. That is one part. Or they may be not able to seeing the face. So it can be both the thing. So what is that we need to judge? Otherwise what happens is they are branded and they become aloof and they find it very uncomfortable to move in any social gathering. Even the parents, sometimes they do not take them to any social gathering because of this issue. They feel very sometimes apprehensive as to how the child is going to react in such a situation. So the whole family needs to come together on that aspect. That also we need to counsel the parent that you cannot hide your child till they become normal. They'll have to move along with the extended family and others. So another example, hydrocephalus, 6 years old, post-VP shunt, delayed milestones, also has hemiparesis, seizures, studies in a special school. And the parents say that he walks around but he cannot see most of the time. Okay, so what does it mean? The functional vision is totally different from what we are assessing. Okay, the functional, with a very poor vision also, the child may be able to function very well. So do not underestimate the visual capacities of any child. And the only problem here is pale disc. So you need to look at the contrast of the materials presented. So you always use a supra-threshold type of stimulus whenever you expect poor contrast or poor visual acuity or both together. And you can use these guides like the cane the training needs to start from very early onwards. But nowadays we have different, if that is difficult, you can make the normal toys which the child uses for such an approach. And inferior field will decide the mobility. So if they are not able to see, the child not getting the milestone of walking, maybe because of the inferior field deficit. So that part you need to remember. So communicable distance, that's important. Then again, this is also similar. The child, 6 months old baby complain of not able to see the mom's face, not fixing or following light, not recognizing mother's face on treatment. So these are the kind of kids that we get usually for the interventions. And so the visual acuity, you have to measure all the visual functions as previously stated. So initially this is over 9 years. So the mother became the therapist in this situation. She started coming to the clinic. Unfortunately, this video is not playing. But what the story is like, over a period of almost 7 to 9 years, the child had gained many of these milestones. They are able to walks with minimal support, differentiate objects, identifies colors, expresses preferences, identifies a person. So they have come a long way. But it is mainly because of the support of the family and the mother who had decided to study on early intervention and actually become a therapist along with the people who are already there. So the ambient lenses, sometimes you may need to use some filters to improve the contrast or colors. Then sensory integration, augmented communication like touch with sight, sound with something. So like that, if you augment, like many of these applications are available in the games on the iPad and all. We have a lot of applications now which can integrate some touch with sighted therapies which we can use. So the Vikas app was developed by the Arvind Madurai team, where they had put in like simple tasks like fixation to mirror, visual closure, figure ground, visual neglect. So all the higher function tests are there in the app, but this is not like some freely available. I think you have to contact Dr. Sahitya if you need access to this testing method. But now they are working on a new one called Percepto app, which will soon be available. The idea is to spread it in the community, like anybody who is coming in contact with the child, like even the immunization people, anybody, pediatrician, if they are having doubt, they can run it, and then they can have like some degree of, with some degree of surety, they will be able to diagnose CVI, and it will also give idea regarding some interventions. So that is the Perceptive app which is going to come. Smart vision glasses in higher function kids, or like the kids who are having very poor vision but with other senses intact, they can use the smart vision glasses, which will give a guide for navigation, people identification of currency, reading, like it will take a photo and it will have it will translate to the Indian languages. So those kind of possibilities are there. The ones which are available abroad are very expensive as compared to this. I think the cost comes around 30 to 40,000, something like that. But if the child is very motivated and high functioning, then this can be tried also, even adults. So many times we have clubbed along with the philanthropists and certain Lions Club and all, who have Rotary, who have distributed these to the patients. Virtual reality again can come in a big way in training, because virtual reality with a headset will block out the other senses, and can be used for vision acuity testing, can be used for field testing, can be used for therapy also in certain children, not all children. So online vision therapy sessions are always useful, because the child is not practical for the child to come in every day. So in between, the child family needs a support, or sometimes to get the compliance, you can connect online and see whether they are following whatever you have told them, and where to schedule the next appointment and all. You can do a hybrid with offline and online sessions. And also you will be able to see the home of the child. So cross disability, like CVA is has association with many other disabilities. So like it can be coexisting with autism, ADHD, Down, cerebral palsy, So you need to be aware of that also. And yeah, so certain cases neuroimaging, may add some diagnostic value, but it may not correlate with the severity of CVI. So don't look at the MRI and say that, okay, this case will nothing can be done. So it is not like that. It will just give additional information. It will say which areas are affected, so you can test for those areas specifically. And see, the visual plasticity, it's variable, very variable, but the sooner you start, the better it is. So it is better to tell the NICU staff onwards. Like if they are having some perinatal insult, all these children need to see not only ROP, but any perinatal insult, even without ROP or resolved ROP, need to see the pediatrician. So this is the summary. Thank you.
Thank you, Sandra ma'am, for that wonderful presentation. It's very happy to know that these things are happening in our country in a very splendid manner. And she explained everything in a very lucid manner. Thank you so much, ma'am.